So currently we have this situation where we treat the patients with growth hormone, which is a recombinant hormone, recombinant human growth hormone that we give patients in order to reproduce the physiology, which is the secretion of growth hormone when we sleep. Of course, there are other systems that stimulate the secretion of growth hormone, which is exercise or amino acid intake. But we mostly secrete growth hormone during the sleep. Do you know the reason why we should produce growth hormone during we sleep? Sorry? Véronique? Spieren, muscles?
Muscles.
Yes, so metabolic. What else? So what can we say? Growth hormone is actually a metabolic hormone. So it makes the muscles less responsive to glucose. So there is resistance to insulin. And the growth hormone is responsible with cortisol for you to have a normal blood glucose when you wake up. So that's the first thing. It's responsible for protein anabolism, which it's difficult to do when you are active. You spend energy to live. And then you have the growth plates that need to be at rest. And for this, you have to lay down. So at least this is the reason why I think we secrete growth hormone during the sleep. So when we provide growth hormone to a child, we try to reproduce that, and I will show you the pharmacodynamics of it later on. This treatment is known for decades now, as Dr. Log just told us. And it works well. You can see here on the right panel that the mean outcome of the patients treated, they usually do 1 centimeters per year of gain of treatment, which is quite good actually. But we have still to keep in mind that a patient under growth hormone is a patient for whom we will give his potential of growth. So we will just reproduce his own potential of growth. We can gain centimeters, of course, for some indications, but most of them are just given their own potential. So the treatment works well, and we know it because there are registries for patients under growth hormone. And we know that the effect of growth hormone therapy is related to the levels of IGF-1 and also of the indications. The side effects of growth hormone are directly related to the IGF-1 levels in a U-shaped curve. It means that when you don't have enough IGF-1, you cannot have a heart that works very well, and you have increased cardiometabolic risk. But when you have too much IGF-1, you also have heart problems because the thickness of the heart wall will be increased, but also you can have the risk of developing cancer. Of course, the cancer that are cited here are for adult patients, and for pediatric, it's mostly cancers of the bones. So we know very well about growth hormone, and it is an efficient treatment. And the question is, why would we need something else? Well, there is a rule of thumb with growth hormone, which is the 25-25% rule, which means that 25% of patients don't take their medications 25% of the time. You can think it's too much, but this is the reality. Think of the patients we see at the consultation that say, yes, I forget it once in a while. And what does that mean once in a while? They say once a week or perhaps 2 times a week. 2 times a week, it's more than 25%. So this is science. And what does that mean? It means that the outcome in height would not be optimal, but also the outcome for body composition and health-related quality of life. So there is room for improvement. And how can we improve growth hormone therapy? By providing more education. It is true for obesity. It is true for growth hormone therapy. We have a hard job, us as pediatric endocrinologists and as many other doctors as well, of course. We can also modify the way we provide growth hormone with other devices. We can also use apps or technical tools to help increase adherence to treatment, but we can also modify the growth hormone as well to reduce the number of doses needed weekly. So what is the current status of that? How can we prolong growth hormone half-life? So we can look back at what was done previously with other treatments as well. In hemophilia, for example, the clotting factor were modified to have once weekly injections, and it works. It improves the metabolic situation of the patient. Also for type 2 diabetes, we talked earlier about GLP-1 agonists. This was done with GLP-1 agonists. You have once weekly injections now, and the treatment is, at least we can say it is encouraging. So technically, how can we do that? We can modify the growth hormone by itself, or we can modify the environment of growth hormone. We can produce microspheres or hydrogels. This is a complex production of the growth hormone that is released very slowly. Or we can modify the structure of growth hormone by adding PEG, for example. PEGylation is very well known. Modifying the amino acid content or fuse with C-terminal peptide. I will just talk a little bit more about this. I will focus my talk on two specialties that will probably be made available in the near future in Belgium. The first one is somatostatin, which is developed by Novo Nordisk. So you have the natural growth hormone. So it's important to remember this is a natural hormone. It's produced in laboratory, but it is the same one. And there is an albumin-binding moiety. It means something that helps the hormone binding albumin, but this is reversible, so it's a reversible binding. And there is something that links the moiety with the growth hormone, which is a hydrophilic spacer. So that is somatostatin. And there is another product that we know already, which is growth hormone linked to the C-terminal peptide of HCG. You will say, what does HCG does here now? HCG, as you know, is a marker of pregnancy. It's actually a hormone that is very resembling to LH, but has a slightly different half-life. But there are several analogs of HCG in the body, so it's difficult to have a specific point about this half-life. But when you multiply the end of HCG in the molecule, then you increase the half-life of the product itself, which is growth hormone. So I said, we have two partners, industrial partners, developing two drugs that will be available in the market either now or soon. The one that is already available is somatrogon from Pfizer for the indication of growth hormone deficiency. And we will probably have in pediatrics soon, we hope, somatostatin for patients with SGA, Turner syndrome, and Noonan syndrome. So how does it work? You inject your product once weekly, and of course you have a different curve of reaction. And the reaction for the drug is based on the IGF-1 levels, because growth hormone induces the expression of IGF-1. So you have all those peaks of IGF-1 with the regular growth hormone once daily, and then with somatostatin, and this is globally the same for long-acting growth hormones, you have a peak in IGF-1 and then a decrease. And so you have to take a little bit the middle of that, which is the dose that you can achieve at day 4. This is on the right panel, the pharmacodynamics of growth hormone. It actually doesn't really work for 25 hours. You also have some sort of a peak. So, and of course, it doesn't reproduce exactly the physiology. So what can we say about the outcomes? The growth outcomes with the long-acting growth hormone are very good because they were tested in comparison with growth hormone by itself. When we take the growth hormone with a normal mean dose, which is 35, here it's 34 microgram per kilo per day. And when we compare that here with somapacitan, there is a non-inferiority of somapacitan, meaning that it is equal. And when we look at the different events that were observed and collected during the trials, then we have a really safe profile of the drugs as per what was retrieved from the trials. What about IGF-1 levels? You have a peak of IGF-1 in the beginning, and then it drops. Of course, there are patients that will have higher IGF-1 levels than the others. This is something that will have to be screened, and it is already known that there will be a need for IGF-1 profiling in those patients. But when we look at the somatrogon, we also have the same results as with the once daily growth hormone. And both hormones, somapacitan and somatrogon, went through all different phases for adult patients, but also for children, of course. So what is needed now in this particular field of long-acting growth hormone, which we call LAG as a summary, is to evaluate, of course, the outcome of the patients that will now be treated. And the focus is needed on the metabolic outcome, of course, because as we said, the outcome with growth hormone is related to IGF-1. So this will have to be monitored with a specific accent on cardiovascular status, because cardiovascular disease is the #1 of the problem in health in general. But we will have to look at bone health too, and pubertal development. And for that, there is a need for phase 4 trials, which means studies after the entry in market. And this is, of course, something that will be done by the scientific societies, but also by the sponsor themselves. Thank you very much.